loading them onto the untitled. Once they're on the untitled, they get set to change overnight in a continuous system. These results are then checked the next day, and the positive sample or suspected sample are picked up before being referred to the various localities for further testing of the.
Okay, that was a short video showing a general idea of what actually we do in our lab, and I go back to my PowerPoint now. Can you all see my screen?
Yes.
Okay, thank you. So what I'm going to do is start with the history a bit. The term IMD was first coined by a British physician, Archibald Garrod, in 1908, beginning of 20th century, and he introduced the one gene, one enzyme hypothesis based on his studies on alkaptonuria, which was the first disease studies, and his textbook was called Inborn Error of Metabolism, and since then we have been using that terminology for rest of the century, basically. PKU was one of the earliest, phenylketonuria was one of the earliest IMDs that was discovered and screening started. It was discovered by Norwegian physician Folling. Are the slides moving?
Yes.
Yeah, okay, great. So it was discovered for Norwegian physician Folling in 1934, when he noticed that hyperphenylalanemia was associated with intellectual disability. He was one of the first physicians, maybe we can call him one of the first chemical pathologists, that realized there was a relationship between chemical analysis and of the body fluids and the disease. So he saw a young woman with two children which were intellectually disabled, and the mother noticed a strong smell of the urine. So he tested the urine for chemistry of the urine, and then realized there was phenyl pyruvic acid in the urine, and so called it phenylketonuria. It is, as we know, a disorder affecting the aromatic amino acid phenylalanine, and it is from a deficiency of PAH, phenylalanine hydroxylase, and if untreated, unfortunately, it can cause intellectual disability and sometimes seizures and other neurological disorder. This is what actually happens. So phenylalanine gets changed to tyrosine by phenylalanine hydroxylase, and this is when it is not working. And then there's a buildup of phenylalanine in the body, in the blood, and it gets changed to phenyl pyruvate and phenyl lactate and acetate, and gets secreted in the urine. Hence that a change in the urine smell and also the chemistry. So that is how it was originally detected in patients with PKU. So as I said, so one of the first diseases to be screened in the UK. Screening started in 1950s with just patchy program where small and labs across the country started to check with phenylketonuria. And at the time, they used a urine test for screening, and they used ferric chloride solution and applied to the wet nappy of the babies when they were about a month and a half or a month old. And health visitors actually went to the baby's home and did that for them. So beginning of the newborn screening, we started from this work on the urine. It was later in 1960 that it was a MRC conference. MRC is the main organization for research in UK, and it was a conference held by MRC, and they recommended that the local authorities should maintain what they are doing for the screening and also expand their program at the time and expand it to the other diseases. So after that, by 1962, I'm sure many of us were not even born there or just about to be born. A majority of local authorities in England, that is mainly the councils that look after all the public health stuff, started to do screening or planning to do the screening. So we are talking about 60 years of active screening there. And it was done, as you saw in the video, it is done on Guthrie card, what's called Guthrie. The name comes from American microbiologist Guthrie, who devised it in 1962. So the blood is dropped on a filter paper, the Guthrie card, and gets dried. And they started with using bacterial inhibition assay, which was introduced in Scotland first in 1964, and the whole of the UK by 1968. So more over like 50 years of doing it. After 4 years of the discussions and intense debate, Department of Health in England and Wales recommended switching to blood-based screening from doing the urine test that they were doing before. And the checking of the blood samples and checking that all babies had been tested was to be organized by local authorities and overseen by the medical officers for health. This is a very important step in newborn screening, because the whole idea of this intervention is that everybody gets tested. And if you miss some people during the process, it's not going to be having a good outcome. So then after that, regional hospital boards, NHS hospital boards, were responsible for setting up regional or supra-regional laboratory services, and they were closely associated with diagnosis and treatment. Our lab is one of them that was established in 1960s. So at this point, we have the basic structure of the newborn screening set up. So we have the laboratories that do it, and it is, I'll show you which laboratories do it in the UK in a minute. And we have a system where all the babies get tested, and we have a system for referral and also very, very tight quality control over the reporting, the whole process, basically end-to-end process. So this is the modern era of the newborn metabolic screening that started, and then after that, other diseases started to be added on. So the first thing that started was PKU in the UK, and this is the system that was established in 1960s. So as we now know, the PKU is diagnosed by elevated serum concentration of feline alanine. So we don't use urine anymore for diagnosis. We can, but it is more sensitive to use the serum. And then if we diagnose a patient with a baby with PKU, with some dietary management and some pharmacological treatment that is now available, it can improve the outcome of the babies, and they can even have a normal IQ and no neurological problem. If the enzyme deficiency is complete, then the phenylalanine can go to very high levels of like 1 millimole or above per liter, or 1200 micromole per liter. There are some borderline and residual enzyme activities that can cause reduced levels of activity and slightly lower levels of the phenylalanine in the blood, and there are cutoffs for the diagnosis that is important to consider when we make the diagnosis for referral to the clinicians from the newborn screening labs. So early years were then started with registering the PKU nationally when they were diagnosed, and there was a steering committee overseeing the whole process. And at the time, several screening centers replaced the Guthrie bacterial inhibition by other methods. So these are methods that are starting to replace the bacterial inhibition. So some places started thin layer chromatography, or then it moved on to more quantitative methods like mass spectrometry that we currently use. In the video I showed you, one of the machines we were showing was the mass spectrometry that we are using currently for newborn screening of PKU. So the developments were not very fast. So for the first 30 years after this, there was no other diseases that was included in the newborn screening, blood spot screening. And it was after 30 years that congenital hypothyroidism was introduced to the newborn screening. I understand that it's currently being done in Sri Lanka. So I think you have a very good structure for starting to expand the service if you wish. So this was screening that started in Canada first in 1974, and the assays at the time were very slow and still radioimmunoassays. They are not used anymore in the UK at all, and most other countries. And that was used to check the the T4 actually at the time. So thyroxine level were used. But as we know, there are a lot of hypothyroid babies that have normal, that have their T4 within the normal range, but still have the hypothyroidism, especially the ones that are below the 20th centile in the reference range. So that started to need something else to be added on instead of, or added or replaced by the thyroxine at the time. So then the second tier was introduced at the time, which was thyrotropin TSH. And as the techniques improved, and it could be done on dried blood sample at the time. So it started with a with the T4, total T4 in the blood spot, and then escalated to the TSH if it was the lower 20% of the reference ranges. So this one could also detect the primary hypothyroidism, the problems with the thyroid gland, and also the central or pituitary dysfunction as well by the changes that was detected in the results. But then when the service developed and used and data came back, it was, as we know now, the secondary hypothyroidism, the pituitary problems are very rare. So in those cases, it became clear that we don't really need to do the T4 anymore, and TSH that mainly shows the primary hypothyroidism, and it is high in those cases, could be enough as a one test for single stage congenital hypothyroidism diagnosis. So that is the next development that happen, then it is a matter of deciding what cutoff you need to get the sensitivity that you require for the positive and negative results. In the beginning, it was set for 80 milliunit per liter whole blood as positive, and then 25 and 80 was borderline. Things have moved. It was a very long process at the time. As you all know, immunoassays took a long time to become a fast and quick test to be done. So at the time, it took 48 hours to analyze one TSH sample or one batch of TSH samples. And then in later years, more diseases were added on in addition to the TSH. Currently, what we are practicing, this is to show you it's one of your recent patients that we had actually. So currently we use a very, very different level, 8 milliunit per liter. So it's a little graph we use. So if they get test in the beginning that is above the cutoff of 8, then we get it repeated twice, and this average is above 8, then it goes to the kind of process of detection or exclusion. So if it is repeated and it is greater, the average is greater than 20, it would be straight away referred to endocrinologist, pediatric endocrinologist, as congenital hypothyroidism. But if it is not greater than 20 and it is between 8 and 20, and then we request a second blood spot test for the baby, and then we repeat it, and we always repeat it once or twice, and then if the average is again greater than 8, then we get it as suspected, and the patient gets referred for further management by the endocrinologist. Usually in our center, the pediatric endocrinologists look after this condition, and they tend to see the baby the same day, really, because the earlier you can start the thyroxine replacement, the better outcome is for the intelligence and all the neurological issues that they may have. So then for expanding the newborn screening, it came to a lot of discussion and debate of what conditions should we actually screen and what is the criteria for screening, because anybody can decide or pick up any disease they are interested in or they are specialized in, and they can bring it up for screening. And then it needs to have a structure and kind of a theoretical basic for what we need to do. So Wilson and Jungner brought 10 principles of what the disease and the service should have in order to be considered for population screening. So in the UK, there is a central kind of authority looking after this, that they review every year the recommendations, and then they follow these principles, and then they decide if that's based in Department of Health, and they decide based on the evidence and the other kind of information that is if that disease can be or should be screened. And this is how the development for other diseases came, that I give you the list in a second. So the condition should be an important health problem, so that you are investing on this and you're causing some kind of comfort problem for the babies, and you're just pinching them and getting blood. So it should be an important health problem. So you start to investing and doing something about it. Should be acceptable treatment available. So if you have a very rare genetic disorder, you can easily pick up by a blood spot, that you can, with a lot of development in the tests nowadays, but still you don't have any treatment. It may not be cost effective or of any value to diagnose them on a screening scale. So it should be a treatment accepted. For example, for the PKU, the treatment, as you saw, was diet and some medications. And for the hypothyroidism, it's just thyroxine, quite simple, straightforward. And cheap way of treating. Facilities should be available. That's the infrastructure that's very important. So it has been set up now in the UK, and I know it is in Sri Lanka as well, so that is not a problem. However, you should consider the platforms that you have and you are doing the tests. So if the platforms are very, very expensive to do the tests, it may not be feasible to introduce it. So it should be considered what facilities you have and what cost it has to expand your screening when you're considering that. Usually with the current situation that we have that I showed you in the video clip, some of the analyzers can test for few conditions together. It doesn't have to be one analyzer, one condition. For example, GSP, the black analyzer, it was on the left-hand side of the video, if you remember. It does the hypothyroidism and the IRT for cystic fibrosis at the same time. So there are combinations of assays that can be put on the analyzers, and this is something you may be wanting to consider if you are expanding your assays in Sri Lanka. So there should be a latent or early asymptomatic stage. So if a disease presented in the first day of birth, it will probably be detected by physical examination and signs and symptoms. You don't need to do the screening. So that is important as well. So almost all of the diseases that have this newborn screening set up, they have a early phase that the baby is completely asymptomatic and no problems. And then you cannot actually diagnose clinically. You cannot go to the signs and symptoms, physical examination and diagnose them. So this is one of the principles, important one from the newborn screening. There should be a suitable test or examination that we have touched on, different assays currently available for many conditions, and we have them for several of them. Should be acceptable. So the way you test should be acceptable. You can't say, okay, I have got a very good disease that I can diagnose and I can give a best treatment ever for that for newborn. And then I start to do a bone biopsy on every single baby in the country. That should be something that is invasive enough to be justifiable. So it should be as less invasive as possible and should be acceptable for the population, for the mothers, for the fathers. They want the babies to be tested, but they want them to be safe as well under the investigations. So that is a very important population kind of basic. And natural history should be also known. If you make a diagnosis and you don't know what happens to the disease after the diagnosis, because it's so rare that nobody has actually gone to adulthood or nothing has gone beyond that, there is no value in doing the population screening test. We should agree on a policy how to treat the patient. Most of these diseases have all of them have a very clear policy. National policies in most countries, they have developed national guidelines for how to treat these diseases, or sometimes international guidelines available for treating them. So it is something that is easily available these days with the information being transferred from one country to the other or from one region of the country to the other. The cost of test case finding is very important as well. So that is the whole process, not only the lab part and the equipment part, the whole process of finding the babies, getting them to do it, cover the whole population, having a specialist to get the report back, and then cost effectiveness. Again, if you have one test available, that gives you the infrastructure to expand. So that would reduce a lot of costs for setting up other tests. And it should be a continuous process and not once and stop. So it should be in every baby that's born every day in the year, and there is no kind of holidays for this. The labs should run the samples all the time. They have a break, but they get all the everyday births in the country and they do it, and it's currently being done. Something about the tests that we do for newborn screening. you may remember from your kind of epidemiologic studies that for any test that we do, we can have false positive, true positive, false negative, and then becomes the sensitivity and specificity of the test. For an outcome of a newborn screening test, it is the same. So you can have a positive, which the patient has the disease, which is true positive. The test says negative, but the baby has the disease. This is a false negative one. And then if you say the patient doesn't have the disease and you say positive by the test, it's false positive. And when it says it is positive and it is the baby has a disease, it is correct diagnosis or true positive. It is very important for newborn screening to have very high sensitivities in this side. So you don't really want false negative in these babies, because that is the whole purpose of the newborn screening. So you should have very, very high sensitivity here. So the correct result to the total result should be very, very high percentage. Usually it's around 99% in most of the assays we do. Specificity also is important. You don't want to start to escalate babies that don't have the disease and you just say positive by the test. But it is not as important. So a bit of it is tolerated and you cannot avoid it. Any test you do, you have to balance the specificity and the sensitivity. But for newborn screening, you go for sensitivity more than specificity. But if you can have both of them very, very high, that's obviously a good thing to have. So then start of developing to technology, the mass spectrometry that we currently have in many labs in the UK started around the 20th century, 1998, and rapidly taken in many, many countries. And PKU is now done, replaced by the mass spec in most labs, and can, in addition to phenylalanine, it does detect all of the other amino acids in the blood, so you can actually have the potential to diagnose other diseases in the same blood spot on the same screen, because mass spectrometry just looks at the whole spectrum of the assays that you're doing. So you don't need extra even testing for that condition if you want, for example, tyrosinemia, if you want to do it. So currently in the UK, the newborn screening program includes 9 conditions: a hematological condition, sickle cell disease, cystic fibrosis, congenital hypothyroidism that we touched based on, PKU, which was the first disease that was in newborn screening, MCAD, which is a fatty acid oxidation defect when the babies can get severe hypoglycemia, seizure, and sometimes death, and usually are asymptomatic when they are born. So this is something that we currently do in our lab and in the UK. Maple syrup urine disease, MSUD, which is amino acid disorder, again can cause serious neurological problems and sometimes acidosis and death, seizures, and some other diseases, isovaleric acidemia and glutaric aciduria, which are classified as organic acid disorders. So these are all detected on the blood spot. So for a clinical diagnosis, if you suspect somebody has isovaleric acidemia or glutaric aciduria, you test the urine for organic acids usually. But for screening, we have ways of carnitine profile where we can detect IVA and GA1 in that, and homocystinuria as well can be detected in the amino acid profile in the mass spectrometry assays that we do. So this is a sample of a patient that was detected, and a letter that goes from our lab to the clinicians. We tell them that this test was done on the baby. Obviously, I've covered the details of the baby, and NHS number and the mother's number, especially important, that is included. Otherwise, there is no way to contact them. Evelina is the Center for Metabolic Disorders in London that we get the patients referred to. Some of other diseases are not detected here, but the PKU is, and we have got the levels on the letter to the clinician. Obviously, we speak to them first before referring it to them, so they have the level. I make it a bit kind of more readable here. So we give them the phenylalanine level, which is very high, above 1,000, probably complete enzyme deficiency, and tyrosine as well. So it has to come with low tyrosine to be confirmed that it is PKU, otherwise it could be other conditions. And then we get them to say that this is, the others are not suspected, or to follow whatever that it's happening. But for particularly for that PKU diagnosis, we give the level, we give the tyrosine level, the date of the specimen taken, it was received in the lab. So this information goes and gets recorded in the patient and also the hospital information system. So currently, these are the labs that in the UK do the newborn screening, and in Ireland. So Dublin has one, Belfast is Northern Ireland that does the other ones, and we have centres across the UK in Scotland and in England, and we are here, Carshalton, south of London, that are part of this network. We have regular meetings with the whole network representation, and we go through quality stuff, and we go through any developments, anything that is planned, so everybody is on board, and it is headed by a person that oversees the whole process. Just a reminder that screening is not only newborn screening, and it's not only blood spot screening. Screening starts from antenatal screening in the UK and in many other countries. So if there is any condition that is inherited, can be detected in deformities of the fetus and other things, or tests for Down syndrome, for example, are done antenatally even before the baby is born. And then when baby is born, in addition to blood spot, it is like hearing tests and other physical examinations that are included as well. And as you know, for adults as well, there are some other diseases that are getting screened, for example, some cancers, breast cancer and bowel cancer after a certain age. So it is as the whole life of a person is exposed to doing a lot of screening tests, and it is a process that deals with the whole life. This is just to show you how complex the whole network is. It is relatively straightforward to talk about it, but in action, actually, a lot of organizations are involved, and they need to coordinate their efforts in order to the newborn screening to be successful. So we are here at the heart. So we are the newborn screening laboratory, and the program center is the one that oversees the whole kind of network of the labs. This is for IRT, for cystic fibrosis, for example. It involves the clinic, the clinicians, if you make a diagnosis, so you refer to them. For the newborn, for the IRT, for the cystic fibrosis, it has 2 stages of testing. It has a genetic testing that the genetic lab does, and also IRT that we do in the lab. So it's a biochemistry and genetics combined. So these should be coordinated, and these are usually coordinated by our lab, so that the right result goes to the right person, and everything is formally documented. And then child health record is very, very important, so that they check every single baby is tested, and if there is not test received for the local lab from that baby, they contact us and say, ask what happened, and then we contact we tell them we haven't received anything, we confirm. They contact the parents, and then they kind of develop a system to get in touch. Occasionally, the parents decline the newborn screening. They have the right to decline, but it is a matter of filling in a form and giving their signature that they don't want their babies to be tested. It doesn't happen that commonly at all. Most parents would like their babies to be tested, but then there is a process for the ones that don't want to do it. And then health visitors that go to the babies to take the blood, and obviously parents are involved here as well. So it is something that is a very complex system, and if anything goes wrong at any step and it's not picked up, then it could be a problem for the whole process. So this is the current situation with the current conditions and what we do now, but there are things in development for near and far future. So SCID is something that's being developed, severe combined immunodeficiency, which is a serious disease. There is a treatment available, and work has been started as trials in the UK, and it is a genetic test, actually a PCR test, a mutation test that can be done. It needs a clean room, and there are new analyzers that can do it quite quickly, and it's currently being tested. We are used as a center to trial the SCID evaluation and see if we can manage to incorporate it to the service. It may go live in the next year or two if the trials are successful and the evaluation is successful. Tyrosinemia, which takes succinyl acetone in the blood, that is the other thing that is being seriously considered. Again, there is a treatment available, and it is being discussed, but after a stage that SCID is evaluated and confirmed. And then congenital adrenal hyperplasia by checking the 17-OHP on the blood spot. That is the other disease that is being developed, and screening for it, and we are thinking about it. So as I said, it goes to a committee of experts and national experts that look at the evidence, look at the other countries that may have done it, and then see what the outcome is, and then they decide what to do. Occasionally, there are diseases that are in the newborn screening service, and then they are removed because there is no evidence that they show they are effective. So homocystinuria, for example, it was in place in some Scandinavian countries for some years, but they couldn't even detect one single patient there because it was so rare there. So some of countries stopped doing it. So the outcome gets monitored all the time so that we know if we are diagnosing the right people, false negatives, false positives, and everything. And these are some references, and I'm happy to take any questions.
Thank you, Dr. Mehdi. Please wait with us. It is time for your questions. You all can talk now, and you can ask Dr. Mehdi to explain anything more if you all wish.
Hello, Mehdi. This is Gaya. So, can you hear me?
Yes, hi.
First, let me thank you for very interesting and very informative talk. Actually, in Sri Lanka, we have neonatal screening only for TSH. So the reason was actually we noticed that there were a lot of undiagnosed hypothyroidism among children and adults. So like by experience, like everybody thought that we should start neonatal screening for hypothyroidism. But all the other diseases like phenylketonuria and even cystic fibrosis, we don't diagnose many cases. And even we see quite amount of no, actually even sickle cell disease is rare in Sri Lanka, but we see congenital adrenal hyperplasia, but we are not sure whether we are missing because cases we don't have facilities even to diagnose them when they come up with symptoms and signs. So like by your experience, what do you suggest for us to do? Like since we have started screening for congenital hypothyroidism, we get samples. So
I think you have got a good infrastructure now that you have a service in place and you have one test to be done. To decide which test should go out, which disease to go after congenital hypothyroidism, probably depends on the prevalence of the disease in your area and which one you want to go first. Maybe you may consider going to the neighboring countries and see what the status of their diseases around is, and then if they have done something similar in other diseases. But all of these diseases, unfortunately, are asymptomatic in the beginning, and a lot of them are missed. So it is really hard to say what the prevalence of the disease is if you don't do the newborn screening. It might come to a kind of expert opinion at some times at your higher level of kind of Department of Health with input from your Royal College to decide and go for diseases that other countries have done, and you think it might be more prevalent in your local population. So yes, you may not want to start with PKU even now because you haven't seen any patients in the last like 20 years. So it should be localized to your local prevalence and what you think is suitable for your population.
okay, thank you.
Dr. Mehdi, you told that you all are doing screening for sickle cell disease. I really like to know what is the method. Did you all check for abnormal hemoglobins in your labs?
The sickle cell screening is done in our hematology lab. I think it is capillary electrophoresis that they do as the method for sickle cell. But they have a secondary test as well, which they escalate for genetic testing when they find positive ones.
Okay, thank you. Okay, I think as there are no other clarifications.
Kisali, one more question.
Yes, you can talk.
Thank you for the comprehensive lecture. Actually, we do neonatal screening program for TSH, as Gaia said. Our cutoff for positive result is 20. And according to your one, first you select 8 and then you repeat the test. Repeat mean with a new sample or from the same sample. So what is the method? I want to know whether our cutoff is okay.
Yes, if it is greater than 20, it becomes straight away suspected. So it doesn't need any repeat. But if it is greater than 8 and below 20, so 8 to 20, we get a new sample. So we get the parents and the health visitor to go and do another sample. And if the second one is still greater than 8, then it is a suspected. So the cutoff is 8, basically, for diagnosis. There is some evidence in kind of Western countries when they moved from 20 to 10 that you may miss some of the hypothyroid babies if you get the cutoff of 20. So there are some papers in the literature if you look, and this is changed in the UK. It was about 4 or 5 years ago, which the cutoff was changed. As I said, it is all done nationally in a network. It's not separate in different. So it's nationally changed from 20 to 10 and then to 8. So it's currently 8. If the first one is not greater than 20, we need a second sample, fresh sample to do.
Thank you.
Okay.
Check again. That's a question.
I saw a question in the chat. I don't think I can.
So what is the suitable timing for sample collection for hypothyroidism? That is the question in the chat.
Sure, we do it in day 5 of birth in the UK, but it can be done earlier as well. So it doesn't have to be day 5. You can even do it day 2 or day 3. but because of logistic problems with getting the babies accessed and then done the blood, so currently it is day 5 of birth. But in some countries, I know they do it a bit earlier, and some countries even do the first 24 hours. In some states of America, they do it in the first 24 to 48 hours. But in the UK, currently it's day 5 of life.
Okay, thank you, Dr. Mehdi.
One question.
Okay, another question for you.
Right, I am Dr. Dayanath, consultant chemical pathologist from Ragama. Thank you for your very informative lecture. I just want to know what is the external QC program for newborn screening for TSH in your country?
Sorry, could you repeat your question?
Yeah, what is the external QC program for newborn screening congenital hypothyroidism?
Oh, okay. So we have the NEQUAS, National External Quality Service, and we work with CDC in America as well. So we have one national one in the UK and one international CDC in the United States.
Okay.
Okay, then I invite Dr. Dilanthi Varavita. She's the Joint Secretary CCPSL. She's a consultant chemical pathologist of Faculty of Medicine, University of Colombo, to deliver the votes of thanks.
Okay, thank you, Dr. Kisali. I hope that you can hear me. On behalf of the CCPSL, let me take this opportunity to thank Dr. Mehdi Mirzazadeh, consultant in chemical pathology and metabolic medicine in Epsom and St. Helier University Hospitals. Thank you very much, Dr. Mehdi, for delivering this excellent presentation amidst your busy schedule. So please accept our token of appreciation, which will be sent to you in few days. And I also thank Dr. Ruvini Ranasinghe, currently working at King's College London, UK, for coordinating this event. And a special thank goes to Dr. Sakuntala Jayasinghe for her contribution today. Finally, I would like to thank all the participants who joined with us from all over the country and asking questions and making this discussion interesting. So hope to see you all in another interesting webinar like this in 2 weeks' time. Thank you very much. Over
Okay,
to you,
thank
Dr.
you very
Kisali.
much.
Thank you.
Thank you.
Thank you.